Welcome to CoPay Accumulator Adjustors Strike Back, what you need to know for your care. This is part of HCC's 2019 Health Access and Patient Advocacy webinars, and I'd like to thank Takeda and Sanofi Genzyme for their support of our 2019 program. Today, our presenter is Kollet Koulianos from NHS, and she'll talk about what these programs are, how to know if you have one, and how this changes how you plan for your care in 2020. Upcoming webinars in 2020 will take a deeper dive into what's next. That's our theme for the year. Topics include the state of the state, advancing advocacy, California Children's Services, issues in women with bleeding disorders, immigration, access to proper diagnosis, and more. Again, you can find more information on upcoming webinars and as well as recordings of past webinars on our website.
What I want to do is make sure that we start at the root of the problem before we can understand the accumulator issue. What drove us to where we are today, and what impact it's having on the community as a result of, for example, healthcare literacy. As you see at the bottom there, the roots of the structure. That's the first one we'll address. A deductible is what you pay before the plan pays 1 penny. So the deductible can be anywhere from a few $100s, and it can be all the way up into the max out of pocket. As what I was able to find in California, the deductibles range somewhere between $500 and $5,000 is the average deductible range. So first you pay the deductible in its entirety before the plan begins to pay a penny. Once the deductible is met on a plan, you then begin to pay what's co-insurance, which is generally like 80-20. The plan will pick up 80%, you pick up 20, and you pay any co-pays until you reach your maximum out of pocket. The max out of pocket for 2020 is $8,150 for an individual or $16,300 for a family. High deductible health plan, in order to qualify to be a high deductible health plan, which allows you to have a health savings account, an HSA, then the minimum deductible on one of these plans has to be at least $1,500. And they can go up all the way up to, in 2020, the most a high deductible health plan deductible can be is $6,900, and that's the max out of pocket as well. So what doesn't count to your insurance is your premium. You pay a certain amount every month for your premium, and that's what pays to get your insurance. If you're in an employer-sponsored health plan and your insurance is offered through your employer, they generally pay a certain percentage of your premium, and you pay a percentage. And you must pay the premium in order to continue to have your health insurance, but that does not count what you pay toward the premium towards your annual out-of-pocket. That's a whole separate line item. So then you have, as we said, we have your options of all the different types of insurance. Now, we covered this already, and you can go back and review last month's presentation, but it's important is that you don't have a basic understanding of the terms and you don't have a basic understanding of the policies, then it is difficult to determine, am I setting myself up for a plan because it looks like a good plan, it has a low premium, this looks good to me, but have I just now put myself in a situation where I'm gonna have much higher out-of-pocket costs? Because if you guys recall, the lower the premium, the higher the out-of-pocket costs are going to be through the year. So the higher the premium, the lower the out-of-pocket costs. So next we talked about healthcare literacy. So it's understanding the basics. And then it's high-cost claimants. So for us, for the community, it's understanding the basic healthcare terms and what kind of plans to pick. But for payers, the people paying the bills, their challenge is managing high-cost claimants. So let's look at what are high-cost claimants. So high-cost claimants, as I mentioned, they're what's being targeted by the employers and the healthcare plans. They're the people that are driving the majority of the spend for these plans. Most of the cost is generally associated with treatment, so high-cost specialty drugs. And so that is, as we see here, this was a Mercer study in National Business Group on Health published this data to say that monitoring and managing high-cost claimants is the biggest priority of health plans as we move into the next 3 to 5 years. So what is a high-cost claimant? High-cost claimants are somebody who costs at least $50,000 in a year. So $50,001 over, you'd be defined as a high-cost claimant. The average, if you take all the high-cost claimants in the U.S. and you average them, they average at $122,382 is what their average spend is. That's 29.3 times higher than the average member on a health plan that's not a high-cost claimant. Only 1.2% of the population are actually defined as high-cost claimants, but that 1.2% of the population accounts for 31% of the spend. So that small, disproportionate share of folks account for, nearly a third of all the healthcare spending by these plans. So of course, that's what they're targeting. And so if you look at the data, the average is 122,382. Hemophilia, we know, and there's different data from different sources. We have several different folks that use different numbers, but a report just came out from Sun Life that says that the average claims for hemophilia are over $400,000 a year. So if you see the average high-cost claimant is 122,382, and that's 29.3 times higher than the average, you can see where hemophilia fits on that radar and why they're also one of the folks getting targeted for driving savings. So what are the top strategies these payers are using? More and more have shifted to high deductible health plans. That's saying instead of having a more rich plan like a PPO, which is probably the most robust plan, if you have a high deductible health plan and the member has to pay a higher deductible before the plan picks up a penny, the member's going to be a lot more conscientious about their spend. They're not going to just run around and get willy-nilly tests and things that are unnecessary. When it's time to get their medications, they're going to pick a generic over a name brand because it's coming out of their pocket. But the problem with our community, as we know, is there are no generics. And so it's not applicable. In theory, this would be a one-size-fits-all option that actually hurts folks that have chronic diseases and no generic alternative. Another big one, you see others on the list here, but another big one is the CoPay Accumulator adjustment programs, and that's a newer strategy. High deductible health plans have been around for a while, so we'll go into CoPay Accumulator adjustments, and that's kind of why we're here today. Showing you the slide here because I'm showing you the number of folks that are offering high deductible health plans, and you see 39% of self-funded plans only offer high deductible health plans. So out of all the folks in the country that are insured on private insurance, approximately 50% are employer funded health plans, and of those, 63% of those are self-funded, meaning the companies are the ones taking the risk. They use other insurance companies to serve as a TPA and administer the claims, but they're the ones paying all the bills. And so 39% of self-funded plans only offered high deductible health plans in this last year. So that number is scary because you can't say to the member, be careful when you're choosing your plan, don't choose a high deductible health plan if that's all that's on the offering. And so, as I mentioned, why they're doing it is keeping the healthcare spend down, et cetera. But over the years, since high deductible health plans have become more and more popular, there's been more and more data that currently 160 abstracts and publications that link an increased cost shifting. In this case, we're shifting more cost to the patient up front. They have to pay a higher deductible, to lower utilization, meaning I can't afford that, so I'm simply not going to get my meds, or I'm not going to have this test. So it might show a decreased cost at first because of lower resource utilization, but with chronic rare diseases like hemophilia, it'll turn out to be a much higher unintended cost of implementing these plans because you're going to have no option but to use the highest site of care, which is your ER or your hospital. So this is from California, LA Times, and so they're called CoPay Accumulators. So as if shifting costs by high deductible health plans wasn't enough, they've now shifting additional costs in the form of these CoPay Accumulators. So what is an accumulator? An accumulator refers to the tracking of a member's out-of-pocket expenditures incurred during the plan year that meets your deductible, your coinsurance, your co-payments until you hit that year's max out-of-pocket. So a health plan would see every time something is spent by you throughout the year on your deductible, and once you meet that, your coinsurance, et cetera, they track that. It's called your accumulator. It's your accumulated spend, And once you hit the max for the year, then the plan has to start paying 100%. So they're watching that number. So what is an accumulator adjustment program is where it's a program used by PBMs, which is a pharmacy benefit manager, that distinguishes at the time of purchase for, let's say, your clotting factor, your other medications. If you use a manufacturer copay card to help you with your deductible or your out-of-pocket, like we have been able to in the past, they're identifying those payments, and they're using that program to identify the payments. And then if that's used, they reset your accumulator. Remember, accumulator is what you've spent. They reset your accumulator to only what you've spent. So if you use a manufacturer copay card, which they let you use, no problem, they aren't counting it to your out-of-pocket any longer. So you're still going to be on the hook for these high deductibles once you've maxed out the copay card. So, here's where the real problem lies, is where high deductible health plans, cost shifting, remember, meet copay accumulator adjustment programs, another cost shifting mechanism, right? It's because they're collecting the money from the manufacturer. And in some cases, if you have a copay card from your manufacturer that's worth $15,000, as an example, and your deductible out of pocket for the year is $5,000, they'll collect $5,000 each of the first 3 months of the year off of that manufacturer card. So they've collected your deductible 3 times. They keep resetting your accumulator every time to reflect but only what you pay. And then on month 4, you have nothing left on your manufacturer card. So it shows that you haven't paid anything. You owe the $5,000. Now they want to collect it a 4th time. So it's far more than double dipping. In many cases, it's quadruple dipping or more. As I mentioned, in 2017, it was over a third of employers offered high deductible health plans, and the number of folks just generally on high deductible health plans, because some choose it if they have other offerings anyway, is 43% of individuals on private insurance. So close to half of the folks who have private insurance have chosen high deductible health plans. And in our community for years, it made sense, because remember, the higher the out-of-pocket, the lower the premium. Well, we were lucky. We were able to use the manufacturer assistance, so we didn't really care how much the out-of-pocket was, because that covered it. The manufacturer copay system covered it. And so we chose the lower premium. But if the plan has implemented one of these copay accumulators, you could be in for a rude awakening. And so it's important to identify if the plan has a copay accumulator, and if you have other options, to carefully consider maybe another option if you cannot come up with that kind of money before the plan will allow you to get your medication. So here's the 2020 spend and savings caps. So I'm going to use the term all other health plans other than a high deductible health plan. When I say other than a high deductible health plan, I mean a high deductible health plan with an HSA. I should have put on there. But so as I said, the max out of pocket for 2020 is $8,150 for an individual, $16,300 for a family. But if you're on a high deductible health plan with an HSA, which means you can save money in a health savings account pre-tax, then the max out of pocket on one of these plans for the year is $6,900. So it's lower, but that can be, your deductible can go all the way up to that amount, and you have to pay that entire thing before the plan pays a penny. Or the family max out of pocket can go up to $13,800. Now, the big problem lies because the proponents of these programs say, well, if you have an HSA, save the money pre-tax and you have no problem. But the max amount, you could, even if you could contribute the max amount to your HSA, there's issues. One, the max amount you can contribute as an individual is $3,550. Well, that's far short of the $6,900 max out of pocket that you'd have to spend. And the most you can save in your HSA for a family is $7,100. Again, far short of the $13,800. And of course, the other problem with HSAs are that if you go to get your medicine early in the year, you can only spend what is actually in your HSA account. It's not like a flex spending plan or a Section 125 that you can take the money out that you've allotted for the year, even if you haven't quite saved it yet. With an HSA, it's only what you actually have saved. So again, be very aware that these have gained in popularity. So here's the amount of folks that have implemented copay accumulators in 2018. And in 2019, we saw by the end of 2019, an additional 19% were looking to use the CoPay Accumulator programs. Now, this data came from 49 payers and PBMs, which represents 147 million commercially insured lives in the country. You know, I showed you that one slide that had all the news articles, 160 some abstracts that show the unintended consequences that happened with high deductible health plans when used on patients with chronic high cost diseases that require life and death treatments. We call them high value. And so when these first came out, and we would go as the National Hemophilia Foundation or a coalition we started on CoPay Accumulators, a coalition called All Co-Pays Count, that has the Arthritis Foundation and HIV/AIDS Institute and NORD and MS and Cancer Society are the steering committee, but we have over 60 member representative organizations now that have joined us in this fight nationally. But one of the things we heard early was, this is a theory. You don't have any data to tell us that there's going to be unintended consequences. And the fact is, there was actually the first data that came out. It was commissioned Dr. Bruce Sherman, who is the medical director of the National Alliance Healthcare Purchaser Coalitions, as well as the other authors you see on the bottom there. And it was something that was published this past year. But they looked at data specific to arthritis, and they showed that an 11.7% refill adherence decrease happened after implementing the CoPay Accumulator Adjuster program. So, you know, the data was actually very clear what happened when patients had to start coming up with that money ahead of time. And then we saw in autoimmune patients, a 29.5% of folks in an HSA had absolute discontinuation rates, which is 4 times higher than those that would be in a PPO. And so these do really affect, the biggest impact will be on people that are on a high deductible health plan with an HSA, because the deductibles are so high and you have to pay that whole thing before the plan starts to contribute. It didn't work here with the high deductible health plans. 160 publications tell us that it didn't work with chronic disease patients that require high value medications. And here's the data, here's facts, okay? So people living with a chronic disease, and you look at that data and you say the median household income in the US is $61,372. That's the median income. More than 3 in 4 people say they live paycheck to paycheck. 2 in 3 people say they do not have enough money to cover a $500 emergency. And then you take that and you look at what the max individual out-of-pocket is of $8,150 for an individual, $16,300 for a family. That isn't inclusive of the premium or all the other expenses of life, home, kids, shoes, food, car, etc. And you see that it doesn't add up. It's going to break, and patients will then be very vulnerable in that circumstance. So I'm going to turn it over for questions, but what I want to also let you know is that we have been working on a state and a national level. We have Virginia, West Virginia, Arizona, Illinois have all implemented bans on CoPay accumulators. We're continuing to work on a state level. The problem with just working on a state level is that the states do not govern self-funded employer plans, which, remember, 63% of all private insurance is self-funded. That's governed through ERISA. So while we have those legislative fixes, if you will, in those states, that's only for people on the marketplace exchange or on fully funded commercial plans. We were able to get HHS and Health and Human Services and CMS to issue in the final rule in January 2020, it was NBPP Final Rule 2020 that said that companies, and that included self-funded plans, could not implement a CoPay accumulator adjustment program if there was not a generic available. So it was really good news for us. We were excited to say, wow, come January, this is going to be fixed. But then in August, they walked the rule back because the proponents of the program say that it could be a violation of the IRS HSA guidelines. So it sits now in limbo. We know they're not going to enforce this rule in 2020, meaning yes, they can still do copay accumulators. And so that's where we're at today. We're going to continue to fight until we get, more permanent fixes. We have had success on a on case-by-case basis. We've also had success with some of the large PBMs to get the hemophilia drugs placed on the preventative drug list, which means that even though it's not going to help you with your deductible and your out-of-pocket costs for all your other healthcare expenditures, if the drug is on the preventative drug list for you, you get the drug at first dollar coverage, no deductible needs to be paid. So at least you're going to be able to access your life-saving medication. So I'm going to open it to questions here.
Kollet, I had a question for you. In terms of the next year or two, what do you see happening with these programs? Are they expanding rapidly? Do you think anyone who wants to implement them has implemented them already? What do you see happening there?
No, I think that they're going to continue to expand, frankly. And the data shows us this. And this past year, United Healthcare, you see every health insurer, all the big ones, the Anthems, United Healthcare, Blue Cross Blue Shield, whatever, they have their fully funded book of business, and then they have their ASO book of business, which would be their self-funded plans. And they act as they just help process the claims. So all the insurance companies, the biggest part of their work is self-funded. And United Healthcare rolled it out this year as an opt-out, meaning for all their self-funded plans, everybody was going to have an accumulator on it unless they opted out. So it took a lot of work, and it's going to continue to take a lot of work to educate these employers because we know very few opted out. So it's going to continue to grow as people are learning of this, employers are learning of this. We're going to continue to fight. But in the meantime, the important thing to note is if you have an option and a high deductible health plan and another option, you really should be careful to look very carefully to see if an accumulator has been implemented. Now, in California, you guys, as well as Massachusetts, there's CoPay. There's already CoPay card bans for drugs that have a generic. So you can't use the CoPay card if there's a generic. So I think that, they've already identified that in California that there is a difference between using a card when there is no generic and when there isn't, if you understand what I'm trying to say. So I think that that's positive for your state. And I was told that from a gentleman in California that he knows that there's potentially an accumulator bill they're trying to get passed, but it will be included with many other things in this bill. And there's language being kicked around, but we don't have anything concrete yet. So I can keep you posted, Robin, and you can certainly share that out as well as this progresses.
Great. And before I read a couple of chat questions and open it up, unmute everybody so they can ask questions directly, I also want to say that if you're in California, you have two programs that can help, particularly if you're an adult, the Genetically Handicapped Persons Program, that goes by the acronym GHPP. It's for people 21 and older, and that you can enroll in that. You don't have to income qualify. It just depends. All income changes is whether or not it's free or if you pay a small percentage of your income annually. And if you have an employer that only offers a high deductible health plan, GHPP is the payer of last resort and can help supplement some of that cost that would otherwise come out of your pocket. There are certain, for medication costs, et cetera. And they can help buffer that a little bit.
I also want to say that the PAN Foundation and the Assistance Fund both have hemophilia copay funds, and where employers and payers will not allow manufacturer copay assistance to count to accumulators when they've implemented these programs, they've all allowed assistance from a third-party nonprofit to count to the accumulator. So if you meet the needs-based qualifications, which is 500% of federal poverty level or below, then you would then be able to have that count. So I do want to make sure I mention that. I'm sorry, and thank you for your comments that reminded me.
Sure. All right, so the questions, the 3 questions we had come in via chat. How does the federal tax law dealing with high deductible health plans impact the state accumulator adjustment laws adopted this year? Are those laws now moot?
Actually, no. We actually reached out to CMS CSIO and asked the exact question, and we said, because we had one health plan already try to come back and say now they have to implement a copay accumulator, and the answer back was no, they don't have to, it's optional, which is comical. And you know, I think it's a very soft argument, because if your child ends up with cancer and goes to St. Jude, they bill your insurance and they don't balance bill anything else, and they accept that as your payment in full. There's plenty of other situations in which it's counted. For example, if you're a member, an associate of Walmart, and you need open heart surgery, they have a center of excellence model where they're sending all the members who would need open heart surgery and one family member to the Cleveland Clinic. And if you go to that center, there's no cost to the employee. And by the way, they only have HSA high deductible health plan offerings for their members. And so they have no out-of-pocket cost. So I do think that, you know, we're going to have, you know, be able to make some inroads eventually, and we're not going to stop fighting.
Great. And another question was, how can you find out if your insurer has a copay accumulator program? Will they share that information?
They don't make it very easy to find in most cases. They come by some really confusing names like copay benefit maximization allowance program. I mean, to most people, including myself, that sounds like a gift. It's far from a gift. So I recommend is if you can get a hold of the plan language as you're researching plans, and especially if you can get a hold of it electronically is the best. And then you do a function find and you look for words like copay, out of pocket, copay assistance, and see if you can find anything in the language. But we have so many examples of myself trying to call and talk to the plans, and half of them don't know what they're talking about or don't confess to, and it's very difficult to find the language. But if you do that search, you can usually find something that'll allude to this.
Okay, that was a comment from someone as well, that their Blue Shield representative couldn't answer the question. So it's good to know that it's really get your hands on that electronic copy of the explanation of benefits and just search your search tools to find it. One more, and our final chat question was, it was just mentioned that there may be copay accumulator language in a 2020 bill in California. Do you have any additional info, and what group is requesting the language, and who, if you know who the author is?
No, but as I mentioned today, when I reached out to somebody that's on our steering committee from the Arthritis Foundation today to just say, have they heard of any language, just to, you know, make sure I covered it. And his response back was he does know of the potential of some language going in a bill with it'll be a kind of a big bundled package bill, but he doesn't have any other information on that. And I certainly will share it with Robin as soon as I get my hands on it, if it does exist, and she can share it out with you guys.
It sounds like we got everybody captured through the chat questions. So before we wrap up, Kollet, is there anything else that you can think of that you would want patients to know in terms of planning for their care, that you would want them to know about copay accumulator adjustment programs?
Well, I think the big thing that I didn't mention is if you're faced with this, let's say your plan does have a copay accumulator, or you didn't see it and they did have one, or they implement one during the plan year. If it does affect you, my advice when you are in that situation is if you try to talk to your employer and see if you can talk to them about what having that language will mean to you, what the unintended consequences of that type of a one-size-fits-all approach will be to you and to them. And I recommend you don't approach it by saying, this is going to affect my quality of life, this is going to mean I may not be able to work anymore, because I promise you there's an awful lot of health plans out there that would be none too happy to have a high-cost claimant drop off their plan because of a decision that they made, and then now it's not their problem anymore. They're not going to say it like that, but I know that's a fact. So it's better to approach it and say, you know, we know that, the Sun Life report that just came out that I mentioned earlier, it says that to go to the hospital or ER, the claims are 10 times higher than on average than home infusion claims. And so you tell your employer, by implementing this, I can't afford, $5,000, $6,000, whatever dollars before I can get my meds. I simply can't do it. So I'm going to be left with no option but to go to the highest site of care, which is the hospital and ER, which could cost you 10 times as much. And that's going to be my only option. And I think when you talk about it and what it's going to cost them, as well as the risk to you, that's where we've had the biggest traction.
And then we have a question from John. Do you want to ask it directly?
I was just wondering, because I was faced with this personally last year with United. We found out a little bit in the year that they had initiated an accumulator. But I found out that, the way that Bayer handles their copay assistance program actually helped me get through that. And I know the earlier year wouldn't have cost me the money. So I'm wondering, has they've approached the other manufacturers to find out how it is Bayer is able to do that, but it seems like no other manufacturer can.
Yeah, so there a lot of them, most of them are doing some sort of workarounds. There's some programs like the Trail Card where it looks like a debit card, or where they're giving the patient reimbursement on the back end in the form of a reimbursement check or some sort of auto deposit. Or the problem with that as a whole, just from NHF's point of view, is that the health plans consider that a huge circumvention of their plan design. And if we get to the point where we're finding workaround fixes to circumvent as opposed to try to fix the problem with them, they're going to dig their heels in further and not even be willing to talk. And we have had some questions raised over, is that going to then put the patient at risk of getting a 1099 for that help because it came in the form of a check or some sort of remuneration to the patient? And then we've also had a couple patients that were asked at the end of last year, and we suspect more will come this year, to sign a letter of attestation from their employer saying, I did not get any sort of remuneration from the manufacturer in the form of a debit card or any other support. And so, we can't tell a patient to lie, but that answer could either cause you have to pay back or even get dropped from the plan and owe back all the money. So it's a dangerous situation. It's not illegal. Clearly, the manufacturers know what they're doing, and I'm not suggesting it is. I'm saying it's not something we're going to promote because we don't want to put our patients in that scenario as a long-term solution. But by all means, everybody has to be able to get their meds. So, you're going to work with the folks that are your partners.
And then we have a two-parter. How do the insurance plans track if they've used a copay assistance card? And then how does this differ when using medical benefits versus the prescription benefit in your plan?
Okay, so for most of them, even United Healthcare, which John, you just brought up, United Healthcare and all the other TPAs, they're rolling that out on the PBM side, because the PBM at the point of adjudication is mostly where they're able to identify that. And then, as I mentioned, these programs identify those payments and then reset the accumulator. But on the medical plans, even United's, they haven't, most can't serve United patients on the medical benefit, but there are like 16 HTCs across the country, for example, that can, and they haven't implemented on the medical side because it's far more difficult for them to do. So we haven't seen any medical language that has adopted this, unless it's like United Healthcare and Optum, a sort of combined deal where they're both, they own both parts, and then they're kind of tracking it through internal communication, but it's less trackable that way. And therefore it hasn't been enforced, so far as I know, in any language.
Well, thank you so much, Kollet, for presenting on this. I know it's kind of a scary and very technical topic. So I really appreciate you breaking it down the way that you did. So thank you, Kollet.
Yes, you bet. Thank you, everybody.
Thank you. Goodbye.